Hi, I'm Katie Allen. I'm a paediatrician turned politician, and I'm constantly asked why change from one of the world's most trusted professions to one of the least. The answer is simple. I want to get inside the tent to help make our future better. Along the way, I've met fascinating people and learned a lot about how the world works. I want to share some of that experience with you, and through my podcast, you'll meet some really interesting people who are helping solve the problems of the world. Reach out to me on socials to let me know who you want to hear from. Join me, Dr. Katie Allen, on An Apple a Week. Hopefully, you'll learn as much as I do. This week, I'm joined by Professor Alistair Chesser. Thanks for joining me on my podcast to talk about health and the future of health.
Well, thank you for inviting me.
So, I know you've been a doctor for a long time and at Bart's Trust, but, the big questions that are coming to healthcare systems around the world are how are we dealing with ageing populations, narrowing tax bases, but also all these sort of new technology, new medicines, digitalisation of health coming at speed. What do you see as the big things for organisations like NHS?
Well, on your first point, the NHS is a huge employer. In many boroughs in the country, the local hospital will be the biggest employer. So we're not just serving society, we are society in many ways. And it's important, I think, that we reflect that in our senior leadership as well as in the rest of the NHS. And the way the NHS is designed, which is much beloved and rightly so, in my opinion, is it's all about equity. Everybody gets equity of access. That doesn't always manifest itself at the moment. And we need to make sure that those groups who find it hard to access healthcare get better access to healthcare. And there's always more to do on that, particularly where I work in the East End of London. What do we need to do? Well, we're living in a world, I think, where people are living longer. And we can do more and more to keep people well and to keep people alive. And that is increasingly expensive. All of that's very good news. But the NHS will always have a finite resource and probably an almost infinite demand made on it. And we're beginning to see how difficult that can be at the moment.
Mm-hmm. And so the NHS is going through digitalisation, like other healthcare systems around the world. I think Matt Hancock famously tried to eradicate fax machines from primary care or GPs' surgeries by 2020. I think that sort of deadline or target came and went. But, is digitalisation coming to the NHS at the sort of right speed, do you think?
I think we all would like to be more digital more quickly. And the way it's developed in the NHS has been somewhat piecemeal over many decades. Having said that, the pace is accelerating, I think. My own hospital, we've just introduced electronic prescribing behind many hospitals, ahead of some others. And that's a step change in terms of efficiency and safety of the way we handle drugs. We're getting better at giving patients access to their records, but we've got a long way to go. We're getting better at communicating with patients in ways other than just writing them letters which go through the post. But again, we do a lot of that still. And we're getting better at communicating with each other within the NHS. But it's still, in many parts of the country, difficult if you work in a hospital to see the GP's records and vice versa, and difficult to see what's been going on in another hospital. And in a perfect world, you would think that would be a no-brainer. So the sooner we get to the point where we can see a patient's health record wherever we are in the UK, and patients get appropriate access to their own records at the same time, the better. And we've still got a way to go on that. And there are still a few fax machines.
Well, in Australia, we've got MyGov, which is, or My Health Record, which is personalised healthcare record that you can access on your device. But it's still not, you can't access it across, through different hospitals. And our problem in Australia is we have a federal and a state healthcare system. So it's even more piecemeal in that way than the NHS. But I presume you have, because it's a more standardised system, or it's all centralised, I should say, a more centralised system. Do you think the opportunity for patients to be, able to access their own
healthcare record is in the foreseeable future, or do you think there are privacy issues that will remain, or consumer concerns?
Well, we do have a central spine in the NHS, and everyone has a unique NHS number, but each hospital has its own IT system, many of the same system, because there's only a few companies building them now, but it doesn't imply interoperability as a given. That all has to be worked through. So the concept of having a single ICT system for the NHS, I think, is one which has been tried and not succeeded in the past. And now it's more about joining up the systems we've got. There's opportunities in there, but it has been frustrating for those working in it, I think, over the last 20 years to see the speed of progress. Having said that, all these things can be joined up. And we've got really an unrivaled set of opportunities in big data for research, for epidemiological study, and for combining stuff for our academics to study. And there's a lot of that going on in the NHS, and there's a scope for a lot more of it to go on. We do need to get over some of the issues around access to data and patients' consent. COVID was a time when we really surmounted some of those barriers by knocking down some of the logistical boundaries to it. But there is rightly nervousness about using data which patients aren't aware that we are using it. So we have to be cautious with that.
It's interesting. In Australia, we had a lot of concerns about COVID Safe app that we developed so that people could, more readily move in and out of sort of restaurants or get about the community, because we had the world's longest lockdown in Melbourne, where I live, and the concern by the public about government having access to data was quite extraordinary when you think about private, internet companies having access to lots of data that we all carry. So there seems to be a real disconnect between being able to be, using data in a useful way and concerns about who owns that data and who is actually controlling that data.
Yes, and it's very, healthcare data is just about as personal as it gets. And so there's a need for reassurance to people, reassurance that the data won't be misused and that the laws are there to make sure it's not misused without consent. But a lot of it is about trust. And if people feel they can't trust healthcare systems or governments or whatever it may be, then there's naturally going to be a reticence to go along with sharing of data. So one can understand why, but I think the more people understand what we want to use data for, which is usually anonymized research for the general good of the population, that's the sort of thing that brings people along.
I mean, I think often, consumers are interested in if it helps them in some way. And I think that's why, the sort of private internet companies, people allow their data to be used because they need to be able to track where they want to go to a restaurant, or they might be using data to communicate with other people. And I think in health, we're not at that point now where people are using data to help their own health, to be more autonomous in their own health. And I remember going to a conference in the US once about 15 years ago, and this great innovator said he used to be, as a cardiologist, someone who would order an ECG for someone who had palpitations, and then they'd have to discuss what next, and it would take days for a result. And now he had this online app that his patients could self-diagnose AF, and they'd ring up and say, I'm in atrial fibrillation, what next, doc? So that power of putting knowledge in the hands of the consumer, including apps on phones to nudge behaviour or to improve the way we sleep or the way we walk or the way we run, those sorts of things are, coming onto the marketplace. But I think often the big organisations are a bit leery about using them. Are you using any of those sort of consumer behaviour support apps within the NHS?
We are. Not universally all the time, but often in innovative areas with practice spreading and trying to overcome the interface with our own ICT systems and all the annoying boundaries we set up for ourselves. But there's more and more of that going on, apps being developed and utilised. so yes, I think is the short answer.
There's a lot of mental health ones, aren't there, particularly?
There are. And we are also at the same time, and catalyzed by the technology, I think, we're seeing the balance of the power dynamic between the healthcare professional and the patient getting shifted in the direction of the patient. Because with knowledge, or with the data comes the knowledge, and then the ability to ask the questions. I don't think any of us really have a problem with that, but it is knocking down some of the paradigms on which our healthcare training has been developed. So it's putting the patient in charge.
I think one of the things to come out of COVID in particular in that way is telehealth, for instance, and patients can spend hours getting across town to an appointment, or sitting hours waiting in a waiting room to see a doctor, and now. And particularly for Australia, because we've got such a big continent, telehealth is really, opening up opportunities for people to be empowered to see their doctor when it suits them.
Yes, and we're doing a lot of it. Really born in COVID. We weren't doing any video consultations to speak of before COVID. The technology's come on, of course, and so has the receptiveness of both healthcare professionals and patients to remote consultations. Having said that, there's a limit. It's very hard to do some things over the phone or on a video call. I think we doctors, healthcare professionals know that you gain a lot from an interaction with a patient by being in the same room.
There's something you can see in the colour of their skin.
The laying on of hands, and that not just diagnostically, but sometimes therapeutically as well. So we'll need to manage that technology carefully and make sure we don't lose some of the magic of the personal interaction.
I think the other thing about medicine is it's becoming more and more standardized, with variation of care being a big healthcare cost. But then the flip side of that is, as you say, there's the magic of bedside manner, laying on of the hands, but also that being able to see something that may not be predictable. Thinking outside the box.
Yes. I think experienced people often can, if not make a diagnosis in the first 10 seconds of a consultation, can be steered towards a diagnosis, often with very little being said. You can't always do that on a video call. Sometimes you can, and I think if the doctor and the patient know each other well, then it's much easier. But when it's a new patient consultation, there's a limit to what you can do without being face to face.
And so post-COVID, I suppose the NHS is facing the same sorts of issues around the world, of both rising costs because there's more expensive medicines coming online. There's hopefully some savings with regards to better use of technology that we just talked about. But there seems to be a bit of a worldwide shortage of healthcare workforce. And I actually find that a little bit hard to understand because I know there's a lot of migration of doctors around the world, but then that means that if they're staying home in their own countries, that must be helping their own countries to have better quality and better numbers of doctors available. But my understanding is that the WHO has predicted there's something like some massive amount of healthcare work care shortages coming at speed, something like 18 million by 2030. So is the NHS looking to address that particular issue? Because it takes years, doesn't it, to train enough doctors and nurses and allied healthcare workers?
Yeah, it takes 20 years to train a consultant and a number of years to train an experienced nurse. And we don't have enough of them. And that's partly because we haven't trained enough and partly because we haven't retained enough. And we have to work at both ends of that, I think. The UK is a fantastic place to train as a healthcare professional. We've got a lot of young people who want to be nurses, want to be doctors. We need to make sure that enthusiasm gets translated into getting them onto training programs, retaining them on training programs, and then keeping them in work once they graduate or qualify. And to do that, I think we're going to need to be more and more flexible with the way in which we allow people to work, part-time working, making sure that they can have a family at the same time as having a successful career or rewarding career for them. And we've got things which we need to do on this because we are relying on imported nurses and doctors. And when and if that supply begins to dry up, as we've seen, that can make it really difficult in the NHS.
So do you have capping of medical places as we do in Australia at the moment?
We do. So obviously to train doctors is expensive. So there's a government-led cap on the number of medical students in the UK at any one time. The numbers have gone up in recent years, but you could argue that they've been too low historically because we struggle to find doctors to fill posts. And we also cap the number of people we put onto training programs to become GPs or to become consultants. So it's very competitive to get into those areas. And then we find a few years down the track that we don't have enough consultants. So the workforce planning in the NHS is traditionally almost always wrong.
It seems that the way doctors are working is changing. So, our generation are doing more part-time, or they're sort of stepping down the amount of work that they're doing, which is adding an extra burden.
Yes. We've got, very generous pension schemes for doctors in the NHS, which at the moment are subject to various taxes, which make higher earning consultants and GPs having to pay significant tax bills every year, which they pay when they stay in the pension scheme. And that perversely is encouraging people to retire earlier. I think we're all aware of that, but it is a problem. But alongside that, the pandemic, I think, has caused many people to reevaluate their approach to work and to work-life balance. And it's tired a lot of people out in the NHS. So they may be thinking about working less than full-time when previously they were full-time, or retiring and stopping altogether sooner than they might otherwise have done. We've got to try and stem that tide because we cannot afford in any sense to lose that experience from the NHS at the moment.
So the COVID burnout's really very real, isn't it, for the frontline workers? They've been through an extraordinary 2 years or 3 years with COVID.
It has. And I think it's been truly life-changing for those who've been looking after patients during this period of time. Clearly affecting some people more than others, but nobody, I think, can deny the effect it's had on the workforce as a whole.
One of my big passions is prevention, having been a paediatrician and worked in research about, I used to joke trying to put doctors out of a job, and people used to laugh politely. But now, if we can actually do better in prevention, that helps the healthcare system, obviously. But the difficulty is that there's so much effort and energy being put into the best and brightest providing the best clinical service. Have you got views about, primary, secondary and tertiary prevention, not just, the lifestyle factors of decreasing smoking and drinking and better exercising, but secondary prevention when people come into hospital with an initial event? How do we get them home? How do we stop them readmitting? How do we prevent them having the nosocomial infections or the wrong medication or the poor outcome because they've been in hospital? Hospitals can be dangerous places even for patients. But how do we also make sure that hospitals have less walls so that hospitals can reach into the homes of patients and support them in situ rather than necessarily having to relocate to a hospital?
We've got a number of things in our favour in the NHS. We don't, in general, have a fee-for-service model. We have had in secondary care for a number of years. That is beginning to change now. And primary care has existed on a capitation basis primarily for a long time. So prevention is in everyone's interests in the NHS. That's a big positive, and one which we have partly utilised, I think. At the moment, we're going through a process of the development of integrated care systems, where budgets will essentially be pooled in every ICS in the NHS. And that, at least in theory, gives us a chance to make sure that we fund prevention programs, population health programs, as effectively as we provide curative and therapeutic programs. It also gives us the opportunity to join up primary, secondary, tertiary, community and mental health care far more effectively than we ever have done before, because we're all now essentially working for the same group, the integrated care system. All of this is absolutely in its infancy, but already I think where I sit, I can see those conversations beginning to happen in a way they didn't happen before. And for 30 years, really, the NHS has been an internal market where we've been competing with each other for resources and for patients. And that is certainly changing into a much more collaborative way of working, catalysed, I think, by some of this change in the legislation.
In Australia, we've got this issue about aged care and healthcare and the intersection between the two. So, our aged care system is, people entering into aged care are getting older and frailer, and that's because the government has actually implemented hospital in the home, or home care packages, I should say, which is supporting people to age at home longer, which is what we know people want. But as a result, the aged care facilities are, filling with people who are older. 50% of them now have dementia as well. And so the clinical support that's needed in aged care facilities is becoming much greater. And there's some argument for the systems are too siloed. So distinction between hospital and an aged care facility sometimes may not be as distinct as we might think. And there's arguments in some ways for having those better, coordinated better together, because most of healthcare costs are in the last year of your life, effectively. And, I just wonder whether the NHS has a view about how it deals with aged care.
Yeah, well, healthcare budgets and social care budgets are usually run separately, but are totally dependent on each other. And at any one time in any hospital in the country, there's a number of elderly people who don't need to be in hospital, but are waiting for a place in the community to go to safely. And we've seen how difficult it is to run healthcare systems if social care doesn't have the resources it needs, and we're still seeing that at the moment. On the last year of life question, I think there's a debate for society about how we die and how we talk about dying. Too many deaths, in my opinion, are still very medicalised. And we've just seen our Queen pass away, and whatever the cause of that was, I think many people look on someone who can live to a ripe old age and then die at home, hopefully peacefully, in an unmedicalised environment. That's something most people would want for themselves and for their families, and yet somehow we fail to deliver that for most of our patients. And that's a society debate as well as a healthcare professionals debate, I think.
I was on the board of Cabrini Health, and we as a board decided that we should activate, if anyone comes in for any reason after a certain age, that they should be having end-of-life discussions, because we know in Australia that particularly things like organ donation or end-of-life directives are quite frequently overturned by families who are unaware of the wishes of their loved ones. So having the conversation at home is regarded as incredibly important.
Yes, and I think that ties in with the importance of continuity of care. It's really hard to have these conversations with patients when you've not met before. But if you've got a relationship with a patient as a doctor or a nurse, and vice versa, if you're a patient and you know your doctor or your nurse, and you know that they know you, then these conversations about what is in one's best interests become much easier to have and much more accessible, I think.
And there's discussions about that in the NHS here, isn't there? Because the GP practices have a certain amount of capitation within their, feeder zone or whatever it's called, but that you have the same named doctor, and that's not necessarily been the case.
That's right. Although I think I don't work in primary care, but I think primary care colleagues would say that a lot of the continuity which they used to provide in days gone by has been lost somewhat, and that's because patient numbers have gone up, GP numbers have not risen proportionately with that, and the simple need to do so many things in primary care, because there's so much more we can do, has eroded some of that continuity which people really value, and I think we all would like to find a way of getting that back.
I was reading recently about, talking about end of life and the flip side of who's left behind. And in the UK, the rate of litigation, I understand, is very high compared to other countries of comparable healthcare systems. And do do you want to sort of explore why you think that is the case in the UK? Is there sort of sense that, the blame game of people feeling they're not being heard, or that there's mishaps that happen that shouldn't have happened, and so patients are feeling frustrated and not heard, or it seems an unusual figure?
Yeah, I haven't got those numbers, but in my experience, litigation is there's often a need for compensation and recognition that things have gone wrong. The moment that gets into the courts, the whole thing becomes not just more expensive, but more difficult for all parties, including those who are making the claim. So efforts to try to ensure that compensation is appropriate and is given to people without them having to fight for it, I think is something we would all welcome. And other countries have done this better than the UK.
Sweden has a no-blame litigation system.
Yeah. But the
or compensation.
The judicial system in the UK is an adversarial one, so one begins to become defensive as soon as one gets into that position, and that can be really damaging for trust in the system, and can lead to allegations that we're covering up information, which is not what any of us want to do. We've got things now in place legally. Duty of candour is in the law in the UK. So hospitals and healthcare organisations have to tell patients when things go wrong, and we do. And that transparency, I think, is important, not just for the way people feel, but actually probably for the amount of litigation which we receive as well. When things go wrong, people often just want some acknowledgement and learning from that, rather than financial compensation.
And so I suppose the other thing I'm really interested to hear about of how the NHS is dealing with things that are coming at us from the future is genetics and genetic screening and genomic testing, diagnostics, therapeutics. How is NHS dealing with that new sector as it's arising, and more generally, how the British people feel about genetic screening, genetic testing and diagnosis?
Well, I can't speak for the British people, I don't think. But we talked earlier about the power of big data in the NHS, and we've got genome projects across the NHS which are really powerful, just simply because of the numbers of patients which can be recruited into these studies, and that's been fantastic. And all over the world, we're moving into a world of personalised medicine, where your genetic profile can influence what treatments, what drugs you're given for whatever disease you've got, and potentially to prevent diseases or to anticipate them as well. And that's incredibly exciting. And it is going to be a revolution, or it's becoming a revolution in healthcare, with the opportunity to improve outcomes, prevent diseases, and save money at the same time. I think the NHS is on board with all this and is embracing these concepts, and is in a good position because of the ability to share data across the system. We've just got to make sure that the bureaucracy which we work in a big healthcare system doesn't get in the way of the innovation.
Excellent. Well, it's been such a pleasure talking to you this morning, Alistair, and thank you for your words of wisdom. I suppose we could finish by saying, what would you say was the most enjoyable part about your job of being head of an NHS trust?
Well, I'm the Group Chief Medical Officer at Barts Health. I'm pleased to say I'm not the Group Chief Executive, which is a job I would not want. And I've worked in the NHS for more than 30 years, and I consider it the best healthcare system in the world, bar none. We are always having a crisis in the NHS, but nevertheless, that ability to provide care free at the point of need to everyone who lives in the UK, I think is a real privilege, and it's one I'm very pleased to be part of.
Fantastic. Lovely to speak to you. So thank you so much.
Thank you, Katie. Thanks for inviting me.
Reach out to me on socials to let me know who you want to hear from. Join me, Dr. Katie Allen, on An Apple a Week. Hopefully you'll learn as much as I do.